all aware of Professor William Coldwell's credentials. He's a familiar name, and there is no better person to follow Dr. Laligam Shekhar in this webinar series than Professor Coldwell. So we'll be having him as our international guest today, and Dr. Arun Srivastav from SGPGI and Dr. Tariq Martin will be the other two people delivering the lectures. So chairpersons for today are Dr. Daljit Singh, Dr. Raghavendran, and yourself. So yeah, I pass on the baton to you guys. Please take over.
Sir.
There's some issue with my network. I don't know. Can we ask someone else to proceed with the proceedings?
Yeah, Dr. Raghavendran is there. Dr. Raghavendran is there.
Dr. Raghavendran.
Yeah, I'm trying to settle down meanwhile. Hello.
Yes,
Dr.
sir. Fine,
Raghavendran?
sir. We understand. Yes, sir.
Yeah, please do.
Dr. Raghavendran, you can start, please.
Yeah, just a moment. So good evening, everyone. I think we have this webinar, and I think everyone is eagerly awaiting, and we have the first speaker for the day is Professor William Caldwell, a professor and chair of the Department of Neurosurgery at the University of Utah. Sir, I welcome you to please deliver your lecture on open surgery for multiple aneurysms, ruptured and unruptured. Please, sir.
Thank you. Let me share my screen. And let me change the format here. Very good. So I think you should be able to see that fine now.
Yes, sir. It's fine now.
Wonderful. Well, it's an honor to be here. I apologize. I was supposed to be in Delhi for the meeting, but we had a terrible snowstorm here, and with plane difficulties, my plane was delayed and I couldn't make it. So I apologize to the organizers of the Delhi meeting, and I'm honored to be here at the invitation of Dr. Sarma to deliver this lecture. Now, when the whole world is becoming more interested in endovascular, I'd like to make a counter argument that I think patients with multiple aneurysms should be treated with open surgery. And I know in India, you certainly treat aneurysms more frequently open than they do in America. In America, the majority of aneurysms now are being treated endovascularly. But I'd like to make a case. This is where I'm from. This is the foothills of the Rocky Mountains. It's a beautiful area. And southern Utah has some of the most dramatic parks in our country and in North America. And we welcome you. This is our Neurosciences Institute, and welcome any of you to come and visit us anytime. I don't have any disclosures that are relevant to this at all. But I just wanted to make the point that we live in an area where we serve a huge population. It's 10 million with just our group, but obviously that's not big from an Indian standpoint. That's a medium-sized city in India, but we serve a very rural population. So there's 10 million people that live in this region here, and they have to come a long distance. And many of them don't have resources to be able to come frequently. So this is an important factor when we consider treating aneurysm patients. So what are your options for treating patients with multiple aneurysms? Well, there's obviously endovascular, which is coiling aneurysms, using the stent coil technique or flow diversion more frequently now. There's open surgical, and then there's a hybrid using both these options. But why do I preferentially want to clip multiple aneurysms? And this is in a paper that's just being published now. This is a series, and I want to talk about this, and I want to talk about the results of this series. So I think that these are all important factors to consider when you have patients with multiple aneurysms. It ensures treatment of ruptured aneurysm in the setting of multiple lesions if you can't tell which one radiographically ruptured, and we've all been in that situation. We can remove clot at the time of surgery, obviously. Immediate relief of mass effect from the aneurysm. And I think the important factor is that when you treat multiple aneurysms through one approach, you don't multiply the risk every time you treat an aneurysm. After you open the head and get exposure, there's only slight increase in risk every time you clip a different aneurysm, which is in contrast to the endovascular techniques. You can treat small lesions or blebs, and we've all seen this on the artery where you have a lot of little blebs that may not be appreciable on the angiogram as well, and you can wrap those, place some muslin on them. And broad or narrow neck aneurysms can be clipped, in contrast to coiling, obviously. And then renal failure patients, I think this is an important one because you don't have any dye load with the treatment. And we may use bypass as part of treatment plan if we can't clip the aneurysm. And this is an option that is always available for you in different parts of the circulation. So I preferentially use open surgery as the first option in cases of multiple aneurysms, whether they're ruptured or unruptured, if they're otherwise in good health. So let's start with this case. This exemplifies a case open surgery. Bilateral MCA aneurysm and a superior cerebellar. Right middle cerebral. It's got a superior cerebellar aneurysm there, small, and a contralateral MCA. Sorry. So, yeah, I apologize. So what I'll do is I'll use a half and half approach. And we'll treat all these aneurysms through one approach. So we'll put the patient in lateral position. Now, I usually use the subtemporal approach when we treat basilar aneurysms, and I'll show you why. So the craniotomy is designed to allow a standard terional approach and a subtemporal approach. Subtemporal approach, right side. You want to identify where the fourth nerve enters the tentorium. Open up the tentorium just behind the fourth nerve. And bring a flap up. This opens up the corridor. The beauty of this approach is it allows you to look behind the aneurysm better and to see if there's any perforators. Here I'm drilling the posterior clinoid. We'll dissect the neck of the aneurysm that's stuck into the pons here. Simple, straightforward dissection. Beautiful keyhole approach. You can see the perforators behind the artery without any difficulty. So now we'll go after the middle cerebral on the same side, on the right side. So we split the fissure. And we identify the complex middle cerebral aneurysm. I use temporary clips frequently and dissect out the aneurysm completely here. You want to understand the anatomy perfectly. Fenestrated clip. Aneurysm is still filling. If you angle the clip a little bit, you can see the tines of the clip better. So we'll put a little bit of muslin here because the aneurysm base, as you saw, had that secondary small aneurysm. Now we'll go ahead and clip the contralateral middle cerebral. This is fairly straightforward. You just fall out from the bifurcation on the other side. Look cross court. Follow M1 out. And there's the aneurysm. Now it's easy to get to, but it's hard to see. We'll use some adenosine arrest here just to help us soften things up and place the clip. This is a very important point. So the problem with the subtemporal approach is that you have to manipulate the third nerve a little bit more. But if you're gentle, most of the time you're working below the third nerve. If you have to manipulate the third nerve, it usually comes back in about 3 to 3.5 months, okay? And I always tell the patients that's an expectation. Often they have a little bit of a third nerve palsy, but it's, I think, a small price to pay, and I'll show you on a bigger aneurysm here shortly. Now, what's the other indication, of course, to treat an aneurysm open is mass effect from the aneurysm. This is an unusual case, and this is a fairly small ACOM aneurysm that's causing visual loss. And you'll see intraoperatively what it looks like. But she presented with visual loss, superior temporal quadrantenopsia, and she's got this MCA aneurysm stuck into her chiasm here. Very interesting. I've seen this a few times, obviously with bigger lesions, but never with an aneurysm this size. It's very interesting. And then she's got a MCA on the right side. So we'll do this open so that we can completely decompress the aneurysm stuck in the chiasm. So again, what we'll do is we'll just do a right approach and treat both aneurysms. Here's her exam 15 months before surgery. And then 3 months before surgery, you can see it's worsened. So she's got bilateral visual loss, superior quadrantenopsia. Okay, so standard frontotemporal approach, right side, and we'll open up the fissure. And the one thing I wanted to emphasize this is if you have multiple aneurysms that you're treating through a common approach, if both or 3 of the aneurysms are down the same corridor, you want to clip the deepest first. So you don't torque the clip on the more proximal one or have to retract the clip on the more proximal one to get deeper. So here we'll dissect out the MCA aneurysm, as you can see here. Very straightforward. And then we'll go, after we've dissected and split the fissure here, we'll go down and clip the anterior communicating artery aneurysm. There's the right optic nerve, the olfactory tract, and we'll go ahead and dissect out the aneurysm that's stuck into the chiasm. Proximal carotid. And you see here now, what I'm doing is I'm dissecting out the aneurysm that's stuck into the chiasm. It's very interesting because you hardly ever see this with an aneurysm this size. I don't know what caused it. So what we'll do is we'll put temporary clips on and dissect it directly, sharply dissect it from the chiasm. So contralateral A1 and straightforward, we'll put a temporary clip. As I said, I use a lot of temporary clips. I usually use Sagita clips. Dissect out the aneurysm from the chiasm right there. And then place a small angled clip across the neck of the aneurysm. Now you can see there's a bleb here on the side of the aneurysm. You want to be very careful. I usually place a little tiny piece of muslin over these, but you don't want to create enough of a scar that's going to interfere with the optic nerve in this location. So you've got to be careful with that. Do an ICG, and then go ahead, and then on the way back out, we'll clip the middle cerebral aneurysm. Straightforward. Okay, so let's now look at another case. If one of the aneurysms is better treated with open surgery or an MCA location, we'll definitely use an open approach because of the middle cerebral location. Here's a patient with a ruptured basilar artery aneurysm, and she also has a left A1, A2 aneurysm. So she's got a subarachnoid hemorrhage from the basilar aneurysm. We could tell that on the regular CT. Small aneurysm. This one can't adequately be treated endovascularly unless you use flow diversion. And then it's dual antiplatelets in the face of subarachnoid hemorrhage, which is a problem. So again, half and half approach, subtemporal and also pterional. So what we'll do is we'll go after the ruptured aneurysm. Here we are, subtemporal approach. There's the third nerve. Takes you between the superior cerebellar and the posterior cerebral. This is a perfect lateral trajectory. It's a small targeted approach. And then what I'm doing here is I'm separating off the perforators off the back of the aneurysm. Now you'll see we'll get an intraoperative rupture here. So we'll place a clip across the neck of the aneurysm. But I want to clip it deeper. So I want to use a fenestrated on this. So we'll go ahead and put a fenestrated clip on lower and take care of the aneurysm. Sprays on the basilar. We want to document with this approach that both PCAs are filling. And then also take a look at the perforators. So we'll go after the ACOM now as well. And that's a straightforward dissection. Do that at the same time. So we'll come subtemporal, and then we'll come in terional and the Sylvian Fisher approach. Now, the next one is a renal agenesis patient. And so you want to be careful with these patients, with the polycystic kidney disease patients and the renal agenesis patients, because you don't want to give them too much of a dialogue. And so this is a strong consideration. She's got a large superior cerebellar artery aneurysm, which is the main target, and we'll clip the middle cerebral at the same time. But again, we'll use the half and half approach. I want to emphasize, I just did publish a series of vascular aneurysms that we've done with the subtemporal approach. And I learned this from Fukushima and also Dr. Drake when he was still alive. And I still use it because I think it's of value. And for the reasons I mentioned, and I'll show you on a larger case in a minute where it's really nice to see. So we'll go ahead, and I can't remember which one. These were unruptured, so I think we may have done the middle cerebral first. And we'll go ahead and clip the middle cerebral. Here's the large superior cerebellar aneurysm. And these are not too much of a challenge, as you know, much simpler. But here I'm opening the dura or the tentorium just behind the fourth nerve. And you've got to be careful when you do this because you don't want to put too much stretch on the fourth nerve. But this really opens up the corridor and usually allows you to put a temporary proximally down at the level below the superior cerebellar if you need it. And so that's why I do that. In this particular case, we could just clip the aneurysm as a straight shot. Beautiful, and you can see the perforators in the back. So very simple. So then we'll go ahead and then clip the middle cerebral aneurysm as I showed you before. Now the next case I want to show you is a complication. And this is an important complication because this is getting a lot of play these days. So this is a woman with polycystic kidney disease. She has a large basilar apex aneurysm and an ACOM, and we'll clip this. She has a wide-necked basilar aneurysm. And what we'll use is rapid ventricular pacing to reduce the flow. Posterior pointing, so dangerous location, dangerous direction. It's embedded in the brainstem there. And so I'll use a subtemporal approach on this, and we have an unusual complication. I'll show you. So half and half technique, as I've shown you before. When you do this, you have to flatten out the floor of the middle fossa. So you've got a perfectly straight trajectory to come in subtemporally. So we'll do the anterior communicator here first. These are both unruptured aneurysms. I always open the lamina terminalis every time I operate adjacent to it. It just ensures good circulation, and also it flushes the blood out, I think, in a subarachnoid hemorrhage patient. Now I'm going to show you the complication we had at the basilar. I usually use a lumbar drain or a lumbar needle when I do the subtemporal approach to just drain CSF quickly. There's the third nerve. So there's the aneurysm. There's the neck of the aneurysm. So she goes into V-fib. And she's in the lateral position, so it's hard for them to do CPR. She was restored with defib after several minutes. So we stopped ventricular pacing, and I just clipped everything off to be able to get the aneurysm neck to deflate a little bit and place the clip across it. So here's the beauty of the lateral approach. Is you see the perforator is perfectly there. I like to deflate the aneurysm to ensure that I can look around it nicely, see the perforators, and make sure that the aneurysm is perfectly clipped. You want to watch the distal end of your clips and make sure they don't grab any perforators coming off the contralateral P1. So she had a stormy course post-op. She went into status and had to be treated for everything was clipped beautifully. She was in burst suppression for 10 days, but ultimately did well. And in a few months, she was back to her baseline. So it's an unusual complication from a subtemporal approach and a ventricular, rapid ventricular pacing. We've published this, but it's just a word of caution when you use that technique. It's not talked about much, but you can develop arrhythmias from the rapid ventricular pacing. So my team reviewed the series that we did of these multiple aneurysm patients and 120 aneurysms. And I just want to demonstrate the durability of clipping of this series. So here's the presentation. About a third of them were ruptured, 2/3 were unruptured cases. And total aneurysms 120. And the outcome, we had unruptured, and we had 3 patients with a residual, 3%, 1 patient with a residual on an unruptured case. And that was because of a perforator placement. And we couldn't clip the aneurysm perfectly to the neck. So very durable treatment. And there's been no recurrences of these cases over the 10-year period that we followed them, that we 2014 to 2024. So very durable. I think, clipping is a very reasonable option for these patients. You can use all modalities of treatment. And in conclusion, I would say that open surgical management should be the treatment of choice for otherwise healthy patients with multiple aneurysms. As increased return on the investment without multiplying the risk. All open techniques are available for use, including bypass, wrapping, and you don't need you avoid the need for stent or dual antiplatelet treatment. And then incidental small blebs or small aneurysms can be treated, whereas this is much more difficult with an endovascular treatment. Avoid a high angiographic diaload, and then less follow-up is needed. And this is a huge issue for us because if somebody comes from Montana and drives down for 12 hours, they don't want to follow up with an angiogram in 6 months, in a year, that type of thing. They want this treated as well as they can, and they want minimal follow-up if they can avoid it, because they can't afford it, and the distance to travel is too far. So that's the conclusion of the paper. So I think that let's not lose the experience that we've got, and let's maintain the best treatment for the patients in these multiple aneurysm patients. And I want to thank you very much for your time.
Thank you. Thank you, Professor, for the wonderful talk.
Thank you, Dr. Colwell. That was a very fine presentation.
My pleasure.
I have two comments to make. So, in case of multiple aneurysms, there's a general perception that the deep aneurysm is clipped first, even though the superficial one is bled, actually. And the other principle which I want to ask you is which side you approach, whether it is the ruptured side or the unruptured side. In case of, I think you showed the bilateral MC aneurysms and
Right. So I operated, yeah, I mean, that was the bilateral MCA one I showed you is a case that were all unruptured aneurysms. And there was two aneurysms on the one side, on the right side, and one aneurysm on the left. That's why I chose the right side, because the predominance of aneurysms are on the right. We'll obviously approach the ruptured with the best opportunity to clip it safely. So if the ruptured should be treated through one approach, but we'll approach an ACOM from either side. I have no problems with that, regardless of the dominance of the A1s, because I think that's a fairly routine operation. I think the complicating ones are the subtemporal approach, which I prefer to come from the right side, because you don't retract on the dominant temporal lobe. And then secondly, if it's a ruptured case and it's a complicated aneurysm, I would focus my attention on that one first and take care of that. So in general, you want to do the deepest one first, but that may change if the more proximal one is ruptured and is fragile. Okay.
Yeah.
So,
yes.
Can I ask a question here?
Sure.
Yeah, Professor Caldwell, two questions for you. Very nice presentation and nice dissections. Number one, in an era of endovascular emergence significantly, how are you able to convince your patient to go for open surgery? One. And number two, I mean, I still find your half and hand approach, it looks like a little larger size of a craniotomy than the conventional Tirional. So how do you, what are your comments on that regarding the size of the craniotomy?
Sure. So it is a bigger operation because you're doing two approaches through one craniotomy. Obviously, you're doing a subtemporal. And the reason that we make it a little bit bigger is you really want about a 3 centimeter flat corridor that's flush with the middle fossa to clip the basilar aneurysm. And so that's why you have to take a little bit bigger craniotomy flap to do that, which I think is a small price to pay because it gives you a much better look behind the aneurysm, especially if the aneurysm is large or it's pointing posteriorly like that one I showed you. Now, as far as convincing the patient, we usually make the case that, you know, we can go after, you can treat the ruptured one endovascularly, but you're going to require other treatment for the other aneurysms, and you can just treat all of them at one shot right now. Because the problem with some of the endovascular techniques, as you're well aware, is that it requires dual antiplatelets if you use stenting, etc. And that may not be the safest treatment for a subarachnoid hemorrhage patient. So we like to secure the aneurysm as best we can, the ruptured one. And then we make the case to the patient and the family that we can treat all the aneurysms at one sitting if you'll allow us to do that. And that saves them, it's more economical for them and safer for them in the long run. So they avoid the multiple treatments. One of the major issues is follow-up for us because of the distances these patients are coming from. And I'm sure you have the same issues once you get into the rural areas of India, where it's just inconvenient and it's impossible to get good follow-up in some of these patients.
Okay.
Professor Caldwell, wonderful presentation. So I'd like to ask, what is your take on blister aneurysms, unruptured blister aneurysms discovered incidentally in a case of ruptured aneurysm, more so in people who are suffering from atherosclerosis? It's nowadays quite common to discover incidentally unruptured blister aneurysms. So how do you decide what to treat, what not to treat?
Right. Well, we'll try to treat everything that we see, as you saw, like we'll either clip a small bleb or we'll wrap it. You can also clip wrap, and I've published a series of patients on that, where you can take a muslin or a Gore-Tex and come around it like a diaper and put a clip across it here to cinch it up and cover the area of blister. And certainly for dorsal blister aneurysms, which are the most dangerous ones, as you know, the proximal ones, that's a reasonable treatment. If you see them and they're unruptured, I would definitely do something with them. I would put some muslin on it, or I would gently clip wrap it, or clip it if you can. The trouble with clipping the blister, the dorsal variant ones especially, is that you'll narrow the artery down if you try to clip it. And I'm sure all the experienced surgeons understand that. So, but I wouldn't prophylactically treat that with a bypass if it was unruptured. I wouldn't do that. I would just bolster it with a muslin or a clip wrap.
Okay.
Thank you, Professor Coldwell. I have a question. So, some of the problems we have in multiple aneurysms, one specifically is if one MCA is ruptured and the other is unruptured, and the brain is full. So you have a problem going to the unruptured side. And the second question is on the bilateral PCOMs. So generally the PCOM is hit by the ICA on the contralateral side. So what's your experience been on these two categories?
Yeah, the PCOMs are very individualized. It depends on the takeoff, how far laterally because you come from, if they're pointing laterally, it's blind to put the clip on around from the contralateral side, as you know. And even in that middle cerebral that I showed you, it's still a little blind because the aneurysm's pointing away from you, right? And you've only got a narrow corridor shot. So we individualize that. So what I tell the patients is that we'll take a look and see if we can do it safely. And we do that with ophthalmics all the time, because sometimes it's easier to see the ophthalmic from the contralateral side, as you know, but you don't have good proximal control. So that's the downside. So we have this discussion openly with the patient, and I tell them, I'll take a look, but we fully understand if the brain's too full or the brain is angry after a subarachnoid hemorrhage, you may not be able to reach adequately, and you may be torquing too much with your retraction to trying to get there. So we'll back off and we'll leave that for another day.
Okay. Thank you so much, Professor Caldwell. Very nice talk and damn impressive.
I had one more
Not
question.
things.
I had one more question, if you don't mind.
Oh, I'm so sorry. Okay, please go ahead.
So sorry. So regarding the half and half approach, extended this one versus a transcavernous approach. So what has been your experience in doing just a what you call a tentorial sectioning and then reaching the basilar system versus opening up the cavernous sinus, cutting the cavernous sinus, and then reaching down? So
Yeah, and we we do the cavernous sinus approaches all the time. I have a big series of cavernous sinus meningiomas and that kind of thing. So I do that very frequently. But the reason that I like the subtemporal approach, and this is as you know, Drake popularized this initially, and Fukushima taught it to me, is that it's a very small targeted approach, and so it gives you that lateral trajectory. And so for the larger aneurysms, I think it's better, because if you come through the cavernous sinus and drill out the posterior clinoid, take down the cavernous wall, etc., and you can do that, it's a lot more work, and then you still don't get the lateral view that you get with a subtemporal approach. There's a nice picture. We just published a series of these patients in neurosurgery just in the last year or so, where we still use this approach 2 or 3 times a year for aneurysms. And the advantage is that unless normally you're coming from a pterional approach, you can look as far lateral as you can, but this puts you direct laterally, and that's the real advantage. So I think you should try it and compare it and see if you like it. The downside is it's a small corridor and you have to manipulate the third nerve a little bit. That's the downside. The upside is that you see the perforators behind the aneurysm much better, and you can actually move the back of the aneurysm forward and see all the perforators. So that was why Drake liked it, and I think that's the reason why we still use it. And I realize that that's controversial, but that's my bias.
Thank you.
Thank you. Thank you so much. So now we move on to second speaker, Arun. He'll be talking on mapping in AVM surgery. So over to you, Arun. You have to switch on your mic.
Very good evening, Daljit sir.
Good evening.
So I'll be sharing my slides. I hope my slides are visible.
Yes.
Thank you, Dr. Pragyan and the team CVSI for giving me the opportunity to talk about brain arteriovenous malformation. And I usually refer them as a enigmatic entity. Why? Because of its varied location, multimodal management options, and lately pooling of lot of contradictory literatures, which really makes it a enigma for we neurosurgeons. The interesting facts are like the overall prevalence is 0.18%, but the huge subset is of asymptomatic one, around 80 to 85%. With the annual risk of about 2%, some literature mention the annual risk high up to 4%. And then a lot of people, younger population, they present with the lobar or parenchymal bleed with AVM as a presenting feature of hemorrhage. To simplify the management enigma, I categorize the events and evidences related to brain AV malformation in 2 time periods. Right. So first being the Spezler-Martin era, which is around 1986 and 90, and it's actually holded nice for 15, 20 nice years, good years. So they have come up with a very simple variables which were accounted was size of the AV malformation and then the eloquence of the adjacent brain and the pattern of venous drainage. Based on that, they classified these AVM in 5 grades, obviously with increasing their complexity and obviously in tune with the complications. So grade 1 and grade 2 were very, very amicable to the surgery and with good acceptable outcome. And obviously with increasing grade, the outcome was not very, very, good. So the reason was very obvious that the size of nidus was increasing, the diffuseness was increasing, as well as the eloquence was the matter of concern, as well as deep venous system drainage. Then the second era, what I want to mention about is the post Spezler-Martin or modified Spezler-Martin era. And the things being the Aruba trial. So the Aruba trial addressed the huge subset of asymptomatic AVM and created doubts and confusion amongst we neurosurgeons. And then other factors came in that the other treatment options like stereotactic radiosurgery, gamma knife, embolization as a staged or as a definitive treatment option. And they started pulling the literature with a lot of evidence-based evidences. But we neurosurgeon, we hold it back because of microneurosurgery being immediate curative treatment option. So regarding this Aruba trial, then came this Tobas trial, and this was actually not a non-randomized trial, it was a registry system, but they very practically and unbiased mentioned about this asymptomatic subset. Though in this group, the asymptomatic subset were only 18%, but they have discussed the microneurosurgery as a safer option for asymptomatic AVM against the natural history, what actually Aruba talked about. Then this paper by the Jiao et al. Is a very interesting paper. I think it's worth going through this paper. He actually modified this Spessler-Martin grading and tried to address those things which were lacking in with the Spessler-Martin grading, because the eloquent white matter tract were not considered in eloquent area mapping. So he also talked about the corticospinal tract and other important white matter tract like optic radiation, arcuate fasciculus. And then he talked about a very interesting fact known as lesion to eloquence distance. And at the end of the paper, he concluded that the hemorrhage as a presentation, diffuseness of the nidus, deep venous drainage, and less than 5 millimeter of lesion to eloquence distance is a factor negatively influence the outcome in cases of brain AVM surgery. So I also gone through Lawton paper, many more paper, and gone through their statistics, their types of study, and what I found important variables affecting the outcome in brain AVM surgery being age at presentation, poor neurological status at presentation, hemorrhage as a presentation, diffuseness of the nidus, eloquent area or eloquent area adjacent to the nidus, and deep venous drainage. So if I say these both end, they are more or less non-modifiable variables to date, but screening can help us. And now we need to understand how cost effective it's going to be. Then coming to the poor neurological status as presentation and hemorrhage as a presentation really challenges the Aruba's trial. If we can address asymptomatic one properly, we can avoid these as a presentation, definitely decreasing the morbidity and mortality due to the AVM bleed, which is at the tune of 2 to 4% per year. Then diffuseness can be addressed with staging or multimodality. So we can go ahead with partial embolization or complete embolization followed by the surgery or stereotactic radiosurgery. Now this area, this eloquent area, this is the area, if we can address this particular subset, this particular variable properly, we can change the outcome in present as well as coming time. So, ladies and gentlemen, actually with this background, I would like to talk about the rationale of intraoperative neuromonitoring in AVM surgery. So actually there have been paradigm shift in the contemporary neurosurgery for each and every pathology. We need to balance between the cure and quality of life. And AVM being most benign condition and curable condition, we as a neurosurgeon need to remember that we have to offer cure at the cost of no morbidity and mortality. There should not be any morbidity or mortality related to the procedure. So that can be achieved with the intraoperative neuromonitoring with the objective of identifying functional areas and tracts. We should be having some system which warns against risky surgical manipulation and allows corrective action at proper time, and as well as can predict post-operative functional outcome, then it will definitely add to the patient's well-being. So this slide was borrowed by Dr. Kuntal. Actually, it's a very interesting slide showing the difference between mapping and monitoring. So mapping is like foot soldiers. They are present there and trying to conquer the enemy, and monitoring is like a sniper sitting somewhere at a distance and performing vigil for to achieve a successful outcome. So AVM being the bag of abnormal vessels, there are actually vascular complications like ischemia as well as mechanical, because we are going to do cortical resection as well as subcortical manipulation. So the ischemia, we all know that it has been proven that somatosensory evoked potential offers the best cortical ischemia mapping, and the motor evoked potential actually gives all the information regarding subcortical ischemic changes. So we ultimately come to know the tract at risk while monitoring through this SSCP and MEP. Then there is a mechanical component. So the cortical mapping helps us in sparing the important cortical area, and the subcortical mapping saves us with the white matter tract. So it actually helps in localization of the functional areas in and around the AVM nidus. So as I talked about this somatosensory evoked potential, it is a continuous, it is a very important tool for central sulcus mapping with the virtue of its reverse phase and reversal phase and cerebral ischemia detection. As I said, it's very, very important and can be done with the help of somatosensory evoked potential. Motor evoked potential can be continuous, and most of the time at our place we are doing intermittently, and this helps in finding out the integrity of the corticospinal tract, and obviously it depends on the anesthetic factors. So we at our center, we follow this Leo et al. Criteria of warning, as well as we also are finding this sensitivity and specificity with this SSCP and MEP monitoring. And we also follow this tips of tip that time, the quickness of your procedures, continuous irrigation with normal saline at room temperature, then whenever required, providing adequate pressure and papaverine installation. These are the gadgets we are having at our place. So few word about anesthetic consideration, that there is some changes in the anesthesia as we are not using neuromuscular blockers, and we are maintaining the intravenous anesthesia amnesia with the help of propofol by continuous bispectral index monitoring. And analgesia is provided by the fentanyl infusion for proper physiological optimization. Then, to know the eloquency of area of nidus or adjacent, we need to know the every details with functional MRI. So TTI with tactography and time of flight and carotid and vertebral artery injections, they actually helped us in localizing the cortical and important subcortical areas. So with this, I'll start sharing some case capsules with you. This is a Medico 19-year-old presented with left-sided external capsule area bleed. But you see the nidus is actually at the surface and subcortical area, and bleed is anterior and medial to that area. So he also had a speech arrest during the time of bleed, and then when it's a some of very old case, so I'm really very sorry for this poor quality angiogram, but it's showing relatively high flow AVM. The arterial feeder is from MCA and the drainage to both the deep as well as superficial venous system. So these are the tract we are supposed to monitor, and with this we have done this procedure. Left-sided craniotomy was done, then hematoma was located with this with the help of intraop ultrasound. Then cortical mapping is usually done with the help of bipolar stimulation. So once we have found no functional area in around this nidus and the clot, we made a small cortical window first to reach to the area of hematoma. And after adequate decompression, the brain become more lax. And then by adding some more corticectomy in silent area of cortices, we started attacking the nidus. So these SCCP also helps in knowing the status of n-Passage vessels. So you can put a temporary clip in n-Passage vessels and then you can see what is happening to the adjacent brain area, how does this ischemia is actually setting in. So ultimately we reached up to the clot area. And now we know that we are close to the posterior limb of internal capsule. The usual microneurosurgical technique, good quality bipolar, continuous irrigation, these all helps in proper coagulation of these pathological vessels. So now we need to monitor the subcortical area as we are reaching close to the posterior limb of internal capsule. So Zion and all, they have talked about the distance of 5 millimeter, but here at our place, we stop at the distance of 10 millimeter, that is 10 milliampere of monopolar current, which are used for the subcortical mapping. So here we have used this monopolar electrode and we were very safe because it was not getting stimulated even with 10 milliampere. So this was excised and the power, which was 3/5 preoperatively, improved and there was no change in with language area, and check angio was absolutely fine. Coming to another case capsule, right parietal avium with a big nidus, taking supply from mainly from the PCA and also from MCA. And just like last case, it was also draining deep as well as superficial venous system. So as I mentioned, that diffuseness of the nidus makes it a very, very difficult case. So here we have gone for the preoperative embolization with onyx. Now it was mentioned that almost 80% of nidus was embolized. And then because of the hematoma and mass effect, this patient was considered for open surgery. Definitely under IONM. All the cortical, subcortical, SSEP and MEP monitoring was done as per protocol. So you see this many of nidus was filling even after the embolization. And in glow, you see the steel phenomenon. All of these abnormal vessels are glowing, but adjacent brain area is not glowing in comparison to the AVM area. So the advantage of preoperative embolization is that you can easily find out and dissect out the nidus. So this is we don't know whether it's a supplying artery or empphysema artery. So clip was applied, and then repeatedly SSCP as a continuous and MEP was monitored. And later on, I remember later on this clip was removed because there was change in scheme. There was a warning signal, and then it was interpreted as ischemic, impending ischemic insult. So it was removed and it was considered as a N-Pesas vessels. So as I mentioned that these embolization may make it easy to dissect from the surrounding brain. So feeder from MCA side and feeder from PCA was cut. The nidus was removed. And ICG shown a complete excision of the nidus. Same was done in few more cases, embolization followed by the surgical dissection like this case. Then this was a case of aneurysm, MCA bifurcation aneurysm with right temporal AVM. So in the first step, after draining the CSF, making the brain lax, we started in antegrade direction from ICA to MCA and then sometime distal to medial to have complete MCA and bifurcation in our exposure. So in this case, actually the SSCP MEP was used because the MCA proximal control and other ischemic insult, impending insult was supposed to be evaluated. And that is why in this case, the SSCP and MEP was used. In this case, the cortical mapping was not done because it was a case of non-dominant side temporal AVM. So after dissecting around the MCA, we reached up to the bifurcation. You can see the aneurysm, but we need to dissect it further to see both the branches and other perforators.
Arun, you will have to speed up because we've exceeded 10 minutes extra already.
Acha, sir, I'm
Yeah, please do that.
so the configuration of MCA has been appreciated, and now this aneurysm was ready to be clipped. So after dissecting it all around, this aneurysm was clipped properly, and then same was confirmed with ICG. And the monitoring does not show any warning signs. And so after this, we proceeded with the excision of the AVM, which was done nicely without any problem, and patient did well. There was no added complication in this case. So the SSCP and MEP monitoring was also done in this case. So I rushed through this case with same idea of knowing the cortical ischemia related complications, subcortical or any long tract. So in this case, we actually did all the 4 monitoring, that is cortical, subcortical mapping, as well as SSCP and MEP monitoring. So post surgery ICG suggestive of good excision. So to sum up, a successful neurosurgical outcome in alocantheria AV malformation is a symphony of precise surgery. Accurate monitoring and stable anesthesia is very, very sacrosanct and required in these kind of cases to give a satisfactory outcome. I would like to acknowledge Dr. Kuntal Kantidas, being the skull base and monitoring director of our institute, Kamlesh being vascular, and Mr. Vivekanand being our very, very important person, being technician of this IONM monitoring and neuroanesthesia team. Thank you so much for your patient listening. Thank you.
Thank you, Arun, for such an exhaustive presentation. Now, because of the constraint of your time, I would first like the next speaker to deliver the talk, and then if the time would permit, subsequently we'll have some discussion common to both the talks. So over to you, Tariq Martin, for endovascular management. Tariq, can you hear us?
Actually, I will be presenting on Dr. Tariq's behalf as he's traveling. So I'm
Okay.
Dr. Devashish. I'm from neurosurgery background. So it's an honor to be in this meeting and represent Dr. Tariq. So are my slides visible?
Yes, visible. Make it full screen.
Okay. So I'll be talking about the endovascular management for intracranial AV malformations. So I would like to say that for every successful curative endovascular embolization, we need 3 things to happen. First, we have to define the lesion accurately, define its architectural compartment, and we are able to accurately predict how it will behave when we are doing the embolization. And then we should have the ability to access with the microcatheter the exact pedicle which is supplying the AVM. And then we should have the ability to master the flow inside the nidus and accurately deposit the embolic material. So flow-directed catheters have been a game changer in the AVM embolization. With the first flow-directed catheter, which is popularly known as the MAGIC, came in 1987, even before the first coiling was done. And many advancements have been occurred. And the flow-directed catheters have a progressive suppleness of the system in the distal part, allowing its easy navigability in the distal parts of the vascular areas. Very distal AVMs, the perforator feeders especially, are easily navigable by these special catheters. So this is the evolution of the microcatheters for AVM embolization. In 1987, we have got MAGIC, and then subsequently we got flow-directed detachable tip microcatheters also in use, like the Sonic and the Apollo, which we are commonly using these days for our cases. So detachable tip catheters have significantly improved the rates because of their very less chances of entrapment and decreased chance of vessel injury while we are pulling out the catheters. So Apollo and Sonic are the commonly used microcatheters which we are using. They have a progressively supple distal end, which helps in their distal tracking. And we have got very, very thin caliber guide wires to help us navigate into the system, which are 007 and 008, 0.008 inches. So also with the coming advancements, there has been a recent randomized trial of, recent trial of Clarirad trial, which is the novel embolic material Optura has been launched, and it has established its therapeutic efficacy because during all AVM embolization, it has been a contention that the onyx and the other materials completely helps blinds us with the EVM, and we are unable to see how much nidus is left accurately and difficult to give stereotactic radiosurgery. This novel material practically disappears after 1 month. So it helps us plan stereotactic radiosurgery sessions effectively, and it will be in the market soon. So coming to the cases, we had a 15-year patient who had presented with left frontoparietal AVM, who had underwent radiosurgery done 4 years back, now presented with bleed, and there was a right side hemiparesis. So we did a CT angiography and found this in relation to bleed. There was an AVM right on up to the motor strip. So this is a MRI which we done. So its location very close to the motor strip. So we did a DSA and we saw this AVM, and this is the APN lateral angiograms showing the AVM with a compressed nidus, and the 3D rotational angiogram showing various dilatations inside the nidus, likely to be the intranidal aneurysms. So we have we have a very good standards of reporting. We have to look carefully amongst all the weak spots inside the AVM, whether in the nidal component, pre-nidal or the post-nidal component, and accurately look at the angio architecture from the 360-degree view. So we always have to have a better understanding about embolization. We need to have a careful look about the architecture, that how our embolic material is going to behave with this. So this is the 3D rotational angiogram in an X per CT view, which helps us look for very small, subtle weak points inside the AVM. So after this, yes, just a second. So I guess one of my slide is missing. So this is Just, I guess there has. Just a second.
I think you can move on the same with the presentation. Okay?
Oh,
We're all getting it.
One slide was actually missing, so
Doesn't matter. Doesn't matter. You can move on further. Right.
okay. So just wanted to show that embolization material is getting deposited. We cannulated the main arterial feeder, and slowly within adequate control, we are just depositing the microcatheter, using the onyx material, getting the layers formed, and then we went ahead. So we need to be careful if there is a sudden flow of the sudden uncontrollable flow, that it means the embolic material has gone to the venous side. So we need to stop our injection at that instance. So like here, I would say, so this is the embolic material going distally. So we have to control and stop our injection at this point, so that it has just layered on the venous side. So we need to be careful, and then slowly we just have to. So after the adequate embolization, we were able to devascularize the medial component of the medial sector, which was adjacent to the bleed. But still the AVM was left. We need to be careful so as not to obliterate the venous drainage of the AVM. And the the IE-Vaso CT showed how much the AVM was left, and this is the embolic cast. And the patient was discharged without any neurological deficits. So coming from the palliative embolization, we have also achieved curative embolization in smaller favorable AVMs. And this was a young child presented with hemiparesis on the left side. And the AVM was So this is a pre-injection showing a small AVM in the parietal region, and there was a intranidal aneurysm. So we had to target that intranidal aneurysm as well, and also adequately embolize the material, and we were able to achieve a complete cure in a single sitting. So this is a post-angio showing no early draining pain. The follow-up angiogram after 6 months also did not show any residual or recurrent lesion. So from this curative embolization, we would like to show this 8-year-old girl child who presented with intraventricular hemorrhage, and the CT angio showed an abnormal lesion. Finally, we did a DSA. DSA was suggestive of early draining right transverse sinus, and in the oblique views, we were able to see a PL-AV fistula near the A2-A3 junction. The 3D rotational angiogram showed this fistula with the venous pouch of AV malformation. As they were very small perforator, tiny feeders, so transarterially they were unable to be cannulated. So we approached via transvenous route, via the Galenic approach. And this is how we entered the vein of Galen and the internal cerebral vein. So with the position was confirmed by the super selective microcatheter injection. And we also inflated the balloon in the mouth of the PL-AV fistula from the arterial side. This was for two purposes. One is to prevent the reflux of the embolic material to the arterial side, as well as to provide a flow arrest so that adequate fistula penetration could be done. we had to use a cardiac standstill via rapid ventricular pacing to achieve the flow arrest. And she was a young girl child. She was only 8 years old. She tolerated this very well, and this helped us to adequately penetrate the fistula. And this is the post run showing adequate penetration with no early draining vein. And the follow-up angiogram after 1 year showed no residual or recurrent fistula. So coming to this third case, where we had, where this was a massive PL-AV fistula, and the whole right P1 PCA was dilated and entering into P1 PCA and P2 PCA was very much dilated, leading to a very high flow AV malformation. And this was the right temporo-occipital fistula. It presented when it ruptured. This is a 3D rotational angiogram, and there are various flow-related aneurysms present on the vertebral artery as well. So to achieve the flow control in this case, we had to use a double lumen balloon. And after inflating this balloon, we were able to achieve this kind of a situation. We were able to safely place our embolic material inside, but still there was a huge suction force due to the fistula. And after we released this balloon, this was after we inflated the balloon, the fistula was still getting filled. And after this deflation of the balloon, the embolic cast moved a bit, but it was adequate to occlude that. So after this layering, we deposited more and more embolic material. So we were able to form a very thick cast inside the right PCA. And this is the embolic cast at the end, and the final angiogram. So there is no fistula at this stage. We are able to see the parenchymogram, which was earlier not visible because of the steel which was happening with that high flow fistula. So apart from this, we are using embolization in the large sectoral for sector embolization of the large cases. So this patient presented with a bleed, and there was CT angio showed a large occipital AVM adjacent to the bleed. So this is the vertebral injection showing a compact nidus, but it was compressed, also compressed by the bleed. So this is a 3D rotational angiogram showing the AV occipital AV malformation. So there was secondary recruitment of the MCA, and we chose to embolize via the transvertebral transarterial route and cannulated the vascular pedicle. We kept our intermediate as distal as possible as could be seen. And then via gradual embolic material embolization, we were able to have a good sector penetration with only using a single microcatheter using the layering technique. And this is the final check angio. So we were able to devascularize a chunk of the AVM. So, but still a lot of residual is left, and the big arterial feeders will be already there and will be planned for subsequent setting. So there was a 26-year male who presented with the ICH, and DSA was done 10 months back, and it showed an AVM in the posterior fossa with the SCA feeders, and we are able to see a dilated venous pouch inside this. So this was the MRI at that time, and over the time that venous pouch got increased, and again the patient had a rupture of AVM. So there was a massive dilatation of the venous pouch. So in these cases, we need to take care of the whole AVM. Otherwise, the venous pouch will not go because of the huge AV shunting which has been going on. So we went ahead with we planned for the patient for a combined approach so as to completely get rid of the AVM. And we did a embolization followed by the surgical excision of the AVM. So this is how we penetrated the SCA feeder, and the microcatheter injection showing the correct position. And then we deposited the embolic material, and we were able to achieve a near total penetration, as can be seen, and the venous filling was significantly decreased, and around 90% of the AVM nidus was embolized. So another microcatheter was also taken, and this was the final result. After the embolization, the venous pouch had some stasis, but it's still visible, although very small twigs of the nidus are visible at present. So patient was shifted immediately to the operating room for the excision of this, and so as to get rid of this venous pouch which was responsible for the bleed. And the AVM was excised in total, and we can see the resected AVM specimen. And post excision, the venous pouch had completely gone, and the patient was discharged without any neurological deficit. And this is the CT head post-op, and he was completely neurologically intact. So as per our opinion, there is definitely a role for endovascular embolization in the AVM because it's a minimally invasive method. It has a preferred role in with the AVM is deep-seated location, and when there are small perforated artery feeders. And it also has a role for the target embolization for reducing the incidence of hemorrhage in intranidal aneurysms. And after that, we can safely subject the AVM for radiosurgery. We can do curative embolization for small AVMs if the morphology is favorable. We can do a sectoral embolization as a part of the multimodality treatment. And when there is a high flow fistulous component, embolization is a favorable. So thank you. Any questions?
Thank you so much for a very nice presentation covering various aspects of AVM. So now we have a couple of minutes for any kind of question, discussion, comments. So first to Arun, if there is any question by any of the person present as on right now on AVM excisions under monitoring.
Yeah, could I ask a question? That
Yes.
was a very interesting talk, Dr. Tariq. What percentage of your small AVMs are you able to embolize completely?
So for a complete embolization, so we require a very good arterial pedicle and this. And there has been recent development of the transvenous approach, which has been expanding the concept of embolization for these small AVMs. So at our center, by transarterial, we embolize completely if it's a small AVM, and generally there is a big feeder, and we are adequately safely be able to penetrate the embolic material inside without getting a significant reflux in the parent vessel. Then we go for the complete kill in those cases. And sometimes the transvenous approach, we have done a few cases as well. And in these cases, in all transvenous cases, we have to go for the complete cure. Otherwise, it will rupture eventually.
Have you seen recurrence after you think it's completely obliterated? Because this is a very controversial issue right now.
So in AVMs, we generally see residuals rather than recurrences, because generally we see that part of AVM could not be embolized safely, we safely leave it and plan it for the next session on the stereotactic radiosurgery. And the recurrences happen when there is a large AV shunting going on and the AVM is growing AVM and it is further recruiting feeders. So then we see much recurrences.
Yeah, I think you've got to be very careful in young
Can I-
patients too.
Just a second.
Comment?
Let Dr. Coldwell complete the statement. Please hold on. Sir, please go ahead. Dr. Coldwell, you were saying something. Please go ahead.
Yeah, yeah, I think you've got to be really careful
Can I
in
interject?
young patients because the young patients can recur, and we've seen it. Obviously, even after excision, especially with the diffuse AVMs, they've got to be watched very carefully. So that's why I was wondering what the true efficacy is over time. I know in neurosurgical focus, we've published papers. There's a Turkish group that is doing a lot of this, where they're trying to obliterate the AVM. And I think it's very hopeful. It's new technology and good techniques and onyx, etc. But we need to see what the long-term follow-up looks like.
Okay.
Can I make a comment?
Yeah, yes, Sri.
So I think the fundamental premise of endovascular embolization as an adjunct, I'm not sure how valid is it for grade 1 and grade 2, which are proportional for a gamma knife radiosurgery. Because the obliteration rates of AVMs from gamma knife is much, much higher than those patients who have undergone embolization and then undergone gamma knife. So I don't think that's a correct statement saying that a lot of AVMs can be embolized completely. We are one of the busiest centers in the world, not only in the country. And I can assure you that the AVM obliteration rate by embolization alone is quite low. On the other hand, our embolization obliteration rates after gamma knife have been around 72-75%. Regarding why we use embolization, we generally use embolization in if we have any weak spots where we feel that the aneurysms which are prone to rupture, or probably if there is a lot of venous pouches and we feel that it might rupture or it might help us during surgery. And that too, we do it mainly with if we're going to get deep feeders and we want to tackle them with embolization, and then which makes the surgical field better. Before radiosurgery, we do it as sectoral embolization to decrease the volume. But with the new gamma knife, I think the necessity of embolization has almost completely disappeared in grade 4 AVMs because we're able to do either fractionated radiation, fractionated gamma knife, either volume staging or by dose staging. So and we have seen many cases in which the AVMs have been tried to embolize completely, have bled on table, and we've had to operate them. So I think anecdotal evidence is one thing, hard evidence is another.
Dr.
Can I make a comment? Can I make a comment?
Yeah, Tati,
I'm
go
Dr.
ahead.
Okay, sorry. I was not. I am traveling. And in fact, I was traveling because I follow my patients. I go to the rural areas wherever we have coiled the patients. We reach them and we. Hello?
Yeah, you're audible. Go ahead.
Yeah. So that's why I was traveling. We reach our patients for follow-up. Okay. So regarding the complete obliteration, I completely agree with Dr. Srinivas that at present, to achieve a complete obliteration of AVM endovascularly, it's anecdotal. We don't have enough evidence that we can embolize completely. Yes, there are two therapies which have coming up. That's a transvenous. Again, the complication rates are higher. We have tried few of them, and a multi-plug technique. Again, we have tried, and we are trying to achieve an curative embolization. Still, they are anecdotal. They are no doubt. So it is mostly palliative. At this juncture, most of the centers, when they're working on a palliative mode for endovascular. Probably down the line, some years down, we may have a curative therapy. A TOTEM trial is going on, and we may try to master the transvenous thing. Then we may have thing.
And the patients who have bled on table when we have tried to do a curative embolization, yes, because we knocked down the vein without taking down the nidus. And that is probably the reason these patients bled on the table. So I completely agree. And we keep on following these patients with very regularly, the young patients. I completely agree with Professor Kodwal on that.
Okay. Any other comment? Any question to Arun?
Raghavendran here.
Yeah, Raghavendran.
Very nice presentation. What is your philosophy regarding this grade 3 AVMs? They are a completely different set of pooled problems. What is your philosophy about this grade 3 SM AVMs?
Yeah, my philosophy is very clear and obvious. I believe if I can bring down those grade 3 to grade 2 and grade 1, means if my issue is size and diffuseness, then adding this pre-operative embolization and making it compact and small and then go ahead for the surgery is one option. Second, if it is complicated by the things like eloquence, so I have talked about this monitoring. So if you know the lesion to eloquent area distance with good MRI workup, that it is more than 5 millimeter, and you'll achieve the complete excision without manipulating those important area. So in that way, you can make grade 3 to grade 2. I mean, what I would like to highlight here is the surgical domain grade 1, grade 2 is very, very clear. We know that it is surgically possible and curable. And compared to any other modality, it's direct, immediate, and cost effective. So these are the factors. We have to individualize each and every cases, and we try to understand what are the techniques or tactics with that a grade 3 or even grade 4 AVM can be bring down to grade 2, and then you can give a very good result. So that is what we follow here at our place, that intraoperative neuromonitoring. We started from 2015 exclusively. So we are doing in all the 4, in most of the cases, in some cases, selected monitoring. So this will definitely change the scenario or changing the scenario.
Okay. Tariq, are you still here?
Still here.
Yeah.
No.
So Tariq, how often you still use NBCA, Nectacril and Lipidol combination?
In cases where we just need a pedicle embolization and target embolization. So that's around 10 to 15% of our AVM, parenchymal AVMs, we use Histocril, 10 to 15%.
And when do you select that?
So it is just a target embolization. The AVM is completely compressed. We need to just drop the glue, or we are seeing a bleeder and an nidal aneurysm there, and we need to block that. So that is the time where we just.
Okay. What about Stickwill and Onyx? So any personal experience on that?
Sir, hello.
What is your personal experience on Stickwill versus
Squid.
Onyx?
The Squid, and we have got an Indian entry also, Minox, which is an Indian-made brand,
Yeah.
and we have got an Indian detachable microcatheters also by Merrill.
Okay. So which one did you find better as an embolic agent? I think he's not.
So out of these 3, only. Hello.
Please go ahead.
And the source of the EVHO from all over the world is a single source. It comes from Belgium. So all the materials are same. It is just the tantalum, the way the tantalum is being mixed. That is one the thing. And the newer material, which is fill and the Optura, these are not an EVHO based materials. So they have got different properties. Optura, we don't have fill. We have tried. And Phil is a methacrylate based compound, and it has got an entirely different property as compared to the onyx and squid. So out of those, squid is our more preferable items.
Okay. So if there are no other comments and questions, I think I'll pass on to Pragyan for the final sitting.
Yeah, thanks a lot, sir. It was truly wonderful, and it was a nice sequence of webinars, and we are all thankful to Professor William Coldwell for agreeing to deliver the guest lecture. We are really thankful, and I sincerely feel that there was no better person than him to follow Professor Laligam Shekhar. Dr. Shekhar started presented in the last webinar, and there was I mean, there couldn't have been anyone better than him to deliver a guest lecture. So we are truly honored, sir, and thanks a lot for devoting your precious time. It was a pleasure to have you today, and also to our
it was wonderful.
two speakers, Dr. Arun and Dr. Tariq, for agreeing to present. Those are two nice topics, wonderfully presented. And I also sincerely thank all the chairpersons, Daljit sir, Dr. Dwarkanath, and Dr. Raghavendran, for willing to become panelists. And we'll be continuing this webinar series in the next month as well. I think Professor Lawton or Professor Ivan Radovanovic will be the next international speaker in the next webinar. So see you all very soon. Thanks a lot. Thanks a lot, everybody.
Thank you.
Thank you so much.
Thank you very much.
Thank you, Professor.
Thank you.
Thank you, Professor William.